Hi, everybody. It's so nice to have everybody on. My name's Monique Hill, and I'd like to welcome you to today's seminar on Do I Need IVF? You will have an opportunity to ask some questions during the webinar. If you look up at the right-hand panel, there's a spot for questions. You can hit that tab and ask the questions you want to ask. I just want to let you know that all of the questions submitted will be private, so you do not have to worry about any of your information being revealed. Also, I just want to let you know that we have more webinars coming up. We do this once a month. And if you want to see some of the webinars we've done in the past, you can go to txfertility.com to see all the Texas Fertility webinars. And we will break halfway in between to answer some questions. And then at the end, you'll have an opportunity to ask some more questions, and we'll try to get to as many as we can. So for now, without any more delay, I'd like to introduce you to Dr. Erika Munch.
Thanks, Monique. Let me know if you guys can't hear me, but I think everything's set up well. Thanks so much for joining us tonight, guys. My name is Erika Munch. I'm one of the physicians at Texas Fertility Center, and this is a webinar designed to answer your questions about fertility, right? So our series addresses a lot of different topics that a lot of patients have come to us over the months and years, saying, this is really good information. I wish I had more information on it in a good place and a reputable place to learn more about those things. So this is a very casual environment in which we can talk, one-sided because I'm talking to a screen, but looking forward to answering your questions and talking about some of the things that commonly come up in fertility care. So tonight's topic, one of my favorites, is actually talking about why people need IVF. Right. And so as a clinician, as a physician, I see a lot of patients who get referred to us, sometimes from their OB-GYN, sometimes from another fertility clinic, and they're coming to see us for a second opinion. They say, you know what, I was told I need IVF. And I don't know if that's true, right? And so they're really looking for some guidance to say, what is IVF? What are the absolute reasons that people need to do IVF? And what are the reasons that maybe IVF is the best choice, even if it isn't the only choice available, right? IVF is a tool in my box, just like any other tool in a toolbox. It can be used at the right time for the right job, but not everything is a nail and not everything needs to be addressed with a hammer. So what we need to do is have very clear reasons for why people need IVF, why there are very clear reasons why people might consider IVF sooner than later, and be able to answer those questions. So the way I like to break this down is first, let's talk about what IVF is, because, the internet has a lot of space medicine out there, and IVF kind of sounds like rocket science sometimes, but I really want to break it down and help people understand what it is, so that way it becomes pretty clear why some people would need to use it in all circumstances. So IVF is in vitro fertilization. What that means is that instead of the eggs and the sperm finding each other in the tubes, they are finding each other somewhere else, and that is in our well-designed 21st century, laboratories, where our very well-trained embryologists and laboratory directors help us build families by allowing eggs and sperm to meet elsewhere, so that way those eggs and sperm can fertilize, create embryos that are small, multi-celled things that eventually grow to a small size that we can put back into the uterus and have a good chance of pregnancy. That's what IVF is. So all the injections help us get eggs. The guys give us sperm, or we use a sperm donor, and then the eggs and sperm meet in the lab because they can't, or we're choosing not to have them meet elsewhere. So when I think about making a pregnancy, I usually need eggs to ovulate. I need tubes for eggs and sperm to meet. I need a uterus that's in good shape for pregnancy. And I need enough sperm to get the job done, right? That's how natural conception would happen in a heterosexual couple. We don't always have all of those parts in all of our patients and in all of their relationships. So there are very well-defined reasons why people might need IVF. And I want to break it down just like I talked about those 4 categories, right? Eggs, tubes, uterus, and sperm. So when we think about eggs, why would somebody need IVF to use why would they need IVF to use their eggs? Well, the simple answer to that is if they don't have eggs themselves, then we would need to establish a pregnancy using eggs from a different source. So sometimes if somebody needs an egg donor because their eggs are either not working or they don't have any, or they went through chemotherapy and their ovarian reserve is gone because the chemotherapy affected the eggs inside their ovaries, they don't have eggs anymore to release. Maybe they don't get periods anymore. Maybe they're essentially menopausal, possibly, premature menopause. If they're not making eggs, we need to establish a pregnancy using a different set of eggs. And eventually that pregnancy the embryo will go up into the uterus, but I'm not relying on their eggs to ovulate and put eggs into the tubes that are going to meet up with sperm. So that's one reason why somebody would use IVF in that case. Or in the case where we're using eggs from, let's say, in a same-sex female relationship, we're using eggs from one partner and they're going to fertilize those eggs with sperm, and then the resulting embryo is going to go into the uterus of the other partner, right? That's another reason that somebody might choose to do IVF off the bat. So that's what I have to say about eggs. Now, one of the primary reasons that IVF was developed, 30 years ago, 30 plus years ago now, was because women would have tubal factor issues that would preclude them from being able to get pregnant on their own. So either that their tubes were completely blocked, or that their tubes were severely affected by previous infections or endometriosis or scarring, or sometimes that they had their tubes tied, right? Either way, if the tubes are blocked, I don't have a place for egg and sperm to meet. So despite, you could be 25 years old and have great eggs, and you could have sperm, hundreds of millions of sperm that are going up into the uterus. But if I don't have a place for that egg and sperm to meet, I can't have fertilization happen, and I can't have a pregnancy, right? So for people that have bilaterally blocked tubes, that is another, or they don't have tubes, that is another reason that people would need IVF. As far as the uterus, most of the time, the uterus is a fairly forgiving organ, and there's not as many reasons why there would be a severe uterine factor that somebody would need IVF. However, if their uterus is not capable of carrying a pregnancy, if they've had significant scarring, if they've had scarring after a previous delivery, if they have fibroids that can't be resected, which is pretty uncommon, or if they've been told maybe by their physician that a pregnancy would be risky, right? So some people have gone through pregnancy before or have had bad pregnancy outcomes, and their doctors have advised them not to get pregnant. We can't use their uterus, right? I can use their eggs, I can use their tubes, but there's no place for the embryo to go. And so in that case, again, IVF would be required to help that family, help that couple build their family, because then I can use their eggs and sperm, and we can take that embryo and put it into a surrogate uterus, right? So that's one of the uterine factors for why somebody would need IVF. And then finally, the other big reason that people sometimes need to go to IVF right off the bat, besides tubal factors, is when we're looking at sperm numbers and looking at their concentration or the amount of sperm that's in the ejaculate, looking at their motility, looking at how normally shaped they are, and kind of their capability, or even the DNA integrity inside of their sperm to be able to achieve a pregnancy. So there are some gentlemen that have normal numbers of sperm. I'm not talking about them. There are some gentlemen that have very low numbers of sperm. And realistically, 90% of the sperm that get deposited during intercourse don't even make it up into the cervix, much less into the uterus. And so there's, the number of sperm that we start out with here, and the number of sperm that end up in the tubes is usually a couple hundred when you have millions and millions down here. So if we're already starting at a low number, or I have a couple that has, the gentleman goes and gets the sperm analysis done, and they say, oh, your numbers are really low, right? Really low numbers is not going to help us get to that egg, because we have to think about all that attrition that's going to happen in the female reproductive tract, and they simply may not be getting a good chance to even have a chance of fertilization if the numbers are too low down here to begin with. So IVF is a way of allowing my eggs to meet up with the sperm. Despite the path being open, if the sperm numbers are low, I may not get there. So IVF is a way for us to be able to essentially ensure that the eggs and sperm are finding each other in the lab, and I don't need that many sperm to be able to cover the number of eggs that I'm going to get in an IVF cycle. And so for what we call severe male factor infertility, IVF can be a good tool to help with that. There are some situations where a gentleman may do a semen analysis and find out that there's actually no sperm in the ejaculate. That's called when they don't have sperm in the ejaculate, what happens is that there's really no opportunity for sperm to find the eggs, even not even a small possibility. And so what a male fertility trained urologist can do is a specialized procedure called a TFC, or testicular sperm extraction, to be able to acquire sperm directly from the testicle. Sometimes that's done if the guy has had a vasectomy before, right? And of course, he's not going to have sperm there anymore. Sometimes that's because there might be a problem in the male reproductive tract with the plumbing where the sperm being made, but it's not able to come out. And sometimes it's just because the testicle has really had difficulties in producing a good number of sperm, and then they do even a more finer micro TFC dissection to take a look at those sperm and identify sperm, and that way we can use them in an IVF cycle. So those are the reasons why people would consider essentially one other reason. If you have a same-sex male couple where we have sperm but we don't have eggs or a uterus, of course IVF is a good way for us to be able to use donated eggs, put them together with sperm, and then put the resulting embryo into a surrogate uterus. So with that being said, far and away the most common reasons that people would need IVF are because the tubes are blocked, or because the sperm numbers are so low that we're not getting sperm up into the tubes to have a chance of pregnancy. There are some egg factors and some uterus factors as well that might compel somebody to doing IVF, but those are the things that I would counsel my patients on to say, yes, we need to do IVF. With that being said, I'd like to break, since I know I have a lot of good questions here, to be able to address those. So as far as, what types of people or individuals need IVF, we have a question about, can you be a single woman and use IVF? Absolutely. So that's not an absolute reason to use IVF, but it is a relatively good reason for some people to do IVF. And I'll talk about that in our second part, as far as when it might be a good idea to use IVF. Women that are single are going to be using donor sperm to help them conceive a pregnancy. They can use donor sperm to get pregnant through insemination, where we're putting sperm up into the uterus. As long as the tubes are open, remember, I still have that chance. Now, the chance of getting pregnant with IVF in general is far and away higher than the chances of getting pregnant through any kind of insemination cycle, because when we do IVF, we're able to get many more eggs than we would if we were doing an insemination cycle using oral medicines or low doses of injectable medicines. And the more egg and sperm combinations I have, the more likely I am to find the egg and sperm that's going to fertilize, continue to grow and divide, and have the right genetics and machinery to be able to make a pregnancy. So in those cases, IVF might be a good idea, and there are compelling reasons to do that, but it may not be your only option. So keep that in mind, especially if you've been told that before. What other good questions do we have? Freezing eggs, that's another good question. Thank you for those questions. So thinking about how to freeze eggs and whether or not IVF is a good option. So interestingly, IVF, the first half of an IVF cycle is actually the same thing that we would do during an egg freezing cycle. So for some women that desire to freeze their eggs to use in the future, what we're doing is we're essentially doing the first half of an IVF cycle. There can be a lot of reasons why women choose to freeze their eggs. It could be, in the news media and such, we think about that like for elective or social reasons. We haven't found the right partner yet, trying to build our career, and we're not ready to have children at this time. And there are other reasons that people choose to do it beyond just those social factors that we talked about. Some people are diagnosed with cancer and they're about to get chemotherapy or radiation or things that are going to affect their egg reserve in the future, and they want to take those eggs and use them now to to freeze them, like to get them ready and get them mature and save them, because we're not using them for pregnancy yet, but we do want to capture them now so that way that person has an opportunity to freeze them later. So they will go through the IVF process, except we're not actually doing fertilization, right? We're not putting them together with sperm yet, but we are having that patient go through the process of doing the stimulation just as if she was doing IVF and trying to get pregnant. She uses injectable medicines. We get those eggs to grow, but we're not waiting for them to meet up with sperm in the tubes. We're taking them out and we're allowing them to cryopreserve them for future use, so that woman can preserve her fertility now and have an opportunity for pregnancy in the future. All right. A question regarding, kind of being told, they've had several insemination cycles and then moving on to IVF, and being told, that's kind of what you need to do. Again, IVF is a good tool, and it's a tool that we use sometimes when other things or simpler, more cost-effective treatments for people in the early stages of fertility treatment are told that they need IVF because other things haven't worked. And again, IVF is a good tool for the right job. And generally, if things are going to work, they work within 3 or 4 cycles. If you've been going through insemination cycles and we're not achieving pregnancy, we're kind of spinning your wheels, right? And we want to move on to a thing that might give us a better chance of pregnancy and be able to overcome some of the things that might be happening behind the scenes, right? It may not be so much about the egg and the sperm finding each other, right? But how many of those eggs and sperm are successfully fertilizing and continuing to grow and divide and making it to a point where they can implant into the uterus. And there might be a small population of individuals where fertilization is not really happening just by introducing the sperm to the egg, and we might need to help that along through some of the techniques we use in assisted reproductive technologies. So IVF can be a good choice. Again, not an absolute requirement, but it can be a good choice, and I'll talk about that next. So absolute indications, remember, tubes are blocked, no sperm or really, really small amounts of sperm present, not using the same source of eggs or uterus as the originating gamete donor. Those are the reasons why people need IVF. All right. Tubal ligation. Also another great question. So some people have had, they've had pregnancies before. They've completed their family building at that time. They were encouraged or decided to have their tubes tied. Now they're in a different place in life. They're potentially with a different partner. Perhaps even that partner doesn't have children of their own, and they really want to build their family together with this new individual. And so those individuals that have had their tubes blocked, remember, that's kind of like an absolute indication for IVF, because if I don't have a place for egg and sperm to meet, then pregnancy is not going to happen. Now, for couples or women that have had their tubes tied, there are 1 or 2 choices that they can do in that situation. They can do IVF, we can bypass the tubes, or they can go through a reconstructive tubal procedure called a bilateral tubal reanastomosis. So that involves a reproductive surgeon or obstetrician gynecologist or whoever's been trained to do these surgeries recurrently to be able to take the make an incision, like a C-section incision, or sometimes laparoscopically, to connect those tubes back together through multiple layers of suturing the muscle wall in the tubes back together. That can be effective in certain situations. Certainly anybody who's thinking about having a tubal reconstruction ought to sit down with somebody like me, like a reproductive endocrinologist, to talk about the chances of getting pregnant that way versus getting pregnant through IVF. Because a lot of times insurance doesn't pay for either, and we want to find the thing that's going to work the best for you. There are many situations where IVF is actually going to be a faster time to pregnancy and more likely to result in a live birth. And there are some situations where the time to pregnancy and live birth may actually be somewhat equivocal between the two. So we want to be able to discuss that with you to help you decide what makes the most sense in your situation. So having a tubal ligation is a fairly compelling reason to go through IVF unless you have that reconstructive tubal surgery. So, all right. If somebody is menopausal, that would be an indication to do IVF, right? If they're not making eggs anymore because they have exhausted their ovarian supply and they've come to the time where the ovarian bank account has run out, essentially, we're not, remember, relying on those eggs to be released from the ovary and make it into the tubes. And that's where we use IVF to help bring the eggs and sperm together in the lab and allow the person to be able to carry the pregnancy, because we're taking the embryo and putting it directly into the uterus once we've had an egg donor. So that, I think, addresses the questions related to absolute indications for IVF. Looking at the amount of questions I have, which are all great questions, I'm now going to switch my focus to when it might be a good idea to have IVF, because I think hopefully you're realizing that there's relatively short list of reasons that somebody would absolutely need to do IVF. There's a relatively longer list about when it might be a good idea to do IVF. So let's think about that again, kind of breaking things down: eggs, tubes, uterus, and sperm. When are these things good ideas? So as far as the ovaries, right? So some people know that they have what's called diminished ovarian reserve, or their bank account in the ovary is not completely exhausted, but it is lower compared to other women. Or they know that during these cycles that have been possibly leading up to this decision, they've gone through Clomid, they've gone through injections, and they're having to use really high doses of these medicines to even get like 1 or 2 or 3 eggs. And it just doesn't seem like, the gears aren't catching, right? It doesn't seem like we're moving anywhere, right? So individuals that have diminished ovarian reserve, we know they don't have all the time in the world to try to get pregnant, right? I mean, everybody wanted to get pregnant yesterday. We get that. But we want to help find the thing that's going to work the best. And when we have diminished ovarian reserve, we may not have as much time to be spinning our wheels, doing insemination cycles. And sometimes diminished ovarian reserve goes hand in hand with ovarian aging and the age of the woman whose eggs we're using, right? And the longer those eggs sit and wait, the more likely they are to have a genetic problem. And the risk of miscarriage and the chances of a live birth, they all kind of go in the wrong direction, as we get older. So for women that have diminished ovarian reserve or ovarian aging, those are good reasons to possibly move to IVF, because again, like I said before, IVF is going to offer us a much higher chance of pregnancy than any given insemination cycle, because we're stimulating the ovary to make many more eggs while reducing the risk of multiples. And that's the other reason, from an egg standpoint, where IVF can be of really good use. So taking it from one end of the spectrum to the other. Now let's talk about somebody who may be fairly, younger, maybe somebody in their 20s or 30s, maybe somebody who has polycystic ovary syndrome, who has really high ovarian reserve, right? You look at their ovaries on ultrasound and you've seen them, you know what your ovaries look like when you have PCOS. You've got lots of these little eggs and they all want to grow. And then we try to use Femara or injectable medications, and it's like lighting up a Christmas tree, and then all of the eggs are ready and your doctor has to cancel the cycle, right? I don't want you to have quadruplets or quintuplets, and I don't want you to have a very high risk pregnancy. And sometimes that can be super frustrating when you want to be a little bit more aggressive, and we just can't do that safely sometimes through an insemination cycle. In an IVF cycle, what we can do is have the benefit of having you have such good ovarian reserve, get those eggs, and minimize the risk of multiples, because nowadays almost always we're putting in one embryo at a time, and we might have the opportunity to cryopreserve multiple embryos and have you go through a single IVF cycle and be able to build your family over the next several years by doing embryo transfers when the time is right, rather than worrying about having all those embryos at once and having a high risk pregnancy. So from an ovary standpoint, it can be very advantageous to think about using IVF when you have diminished ovarian reserve. It can also actually be very helpful when you have really high ovarian reserve or very sensitive ovaries where we're getting too many follicles in an IUI cycle and not being able to use them. As far as the tubes, some people say, well, if I only have one tube, does that mean I only have half the chance of getting pregnant? And that's not technically true, right? Because the tubes, as long as they're mobile, one tube can reach over and pick up eggs from the other side. But certainly, we always like it when the eggs are developing on the side where we know that the tube is open. And with an IVF cycle, we know that we get to use eggs from both sides, and we don't go through your tubes to get to those eggs. And I get to have the benefit of having twice the number of eggs that I might have access to if I was only, having the one tube be open or functioning. Some women will say, well, I have, a swollen or a damaged tube, and I'm worried about that. That can be a relative indication to pursue IVF. Certainly, if the tubes are so swollen that they're full of fluid and they're not spilling dye, that's probably a reason to go to IVF off the bat. Some women will have swollen tubes, and maybe the dye on the HSG spills out a little bit, and we say, well, maybe it's kind of working, but you're not getting pregnant. Again, it makes more sense to take that investment and put it towards the thing that's going to work the best, which is bypassing that damaged tube. As far as the uterus, generally, there are a few reasons why somebody might be more convinced to do IVF if there was a uterine problem, because usually uterine problems can be addressed surgically by removing fibroids or polyps. And like I said, there's some absolute reasons people would need IVF, but generally we've addressed those already. As far as sperm, again, thinking about looking at the sperm numbers and their motility and concentration, there are relative reasons that people might choose to use IVF early on. Maybe they have enough sperm to make, inseminations a technical possibility. Certainly we want at least, it'd be nice to have at least 10 million sperm that we're doing when we're doing inseminations that will lead to the highest chance of pregnancy. And if we're not getting there, or we're having to do multiple back-to-back IUIs and we're really struggling, and it's hard to have you come in multiple times and worry about the timing and everything. Some couples may find that it might be more effective and possibly less stressful to be able to do IVF, where we really only have to worry about one sample collection and we're golden. So for some individuals, that lower sperm number may be compelling for them to go to IVF sooner. Certainly a male reproductive urologist would have some insight as to whether or not there might be other factors that might have people, if they're not responding to oral medicines to improve sperm numbers, they might be encouraged to go to IVF. One interesting point, and this is kind of more of a financial point more than anything else, is that for some couples, they're using donor sperm, right? That can be a same-sex couple, that could be a heterosexual couple where the gentleman does not make any sperm and we're using donor sperm to help them build their family. Either way, donor sperm are expensive and not always free and easily accessible, right? So the amount of sperm that we need to do IVF with is actually less than it is for us to do inseminations with. So vials of sperm in general are cheaper when you're using them for an IVF cycle than they are for an insemination cycle. And sometimes just it becomes cost prohibitive for couples to use multiple vials of sperm to go through insemination cycles with a modest chance of pregnancy, rather than making the investment to do IVF and spend money on, a single vial of sperm and have a much higher chance of pregnancy and opportunities for pregnancy potentially in the future. So that's reasons where IVF may be a good idea or something to move to sooner. Finally, I want to speak a little bit to the question about genetic testing, right? So as you guys have probably read online, when we do IVF, there is an opportunity to do genetic testing on those embryos. That is called pre-implantation genetic testing. Now, what that means is that before an embryo is cryopreserved, before we would put it into the uterus, we have an opportunity to see that embryo in the dish. It's a couple hundred cells. It's just a little ball. It doesn't look like a baby. It's just a ball of cells, but we know that there are cells in that embryo that we can safely sample to count the number of chromosomes or look for single gene defects, right? And that technology is called pre-implantation, because we do it before the embryo goes in, pre-implantation genetic testing. There are two reasons that people do this. One reason might be because they know that both members of the reproductive couple, the egg and the sperm, they're both carriers for something like sickle cell trait or cystic fibrosis or certain types of muscular dystrophy or spinal muscular atrophy. There might be something where if you carry a trait you're not sick, you just carry this trait around like a silent carrier, and your partner has this trait, then the baby that you guys could make together might end up inheriting your abnormal trait and their abnormal trait and end up being born with a disease, right? And that is something called an autosomal recessive disease. So in genetic testing, what can be done with the embryo is that if you're both found to be carriers for the same condition, you can actually test the cells of the embryo placenta tissue, essentially, to see whether or not that embryo has inherited both of those abnormal copies. And I've had my own patients that have gone through this for a variety of diseases and conditions, because maybe they had a family member pass away in their family due to this condition, or baby got sick and didn't live past 6 months old, and they want to ensure that this is not going to potentially happen for future pregnancies. So they will go through IVF specifically for the purpose of doing genetic testing on those embryos to ensure that when they are transferring those embryos back, that embryo should not, have a heightened risk of developing those conditions. So that's one reason that people do IVF, is specifically for that genetic testing. Not an absolute, but definitely a risk reducing strategy for those couples. They don't have to get pregnant through IVF, but it's generally a good idea. The other reason that people sometimes will do IVF sooner than later is because we have the opportunity to do genetic testing to count the number of chromosomes. And that's called PGTA, or looking for genetic testing related to aneuploidy, or an abnormal number of chromosomes. As we get older, our eggs are more fragile on the inside, and the DNA inside those eggs is more likely to not divide evenly when the egg comes out. And so sometimes eggs get too much DNA or not enough DNA. And that's why as we get older, the risk of miscarriage goes up, or the risk of not getting pregnant is a possibility. The risk of having a baby that has Down syndrome or trisomy 13 or 18 goes up. And for some couples, they know that their risk of miscarriage is going exceedingly higher than they're willing to tolerate, and they say, well, what is the thing that you have that can reduce my risk of miscarriage, right? And really the only tool that we have in the box that we can reduce the risk of miscarriage is to know that embryo is starting out with the correct number of chromosomes. It doesn't obviate the risk, it doesn't make it go away, but it greatly reduces it, and now it takes age out of the equation. So if I can test those embryos and I see that they don't have the normal number of chromosomes, then potentially we've avoided transferring an embryo that would lead to a miscarriage down the road. If I can test that embryo and know that it has 46 chromosomes, and I place it in, and we have a higher chance of pregnancy and a greatly reduced risk, not a zero risk, but a greatly reduced risk of miscarriage. And for some couples, that's important because now the time to pregnancy may be faster, and the risk of miscarriage and all the things that happen after miscarriage that delays the next pregnancy is greatly reduced. So those are the reasons why it might be a good idea to do IVF sooner than later. Not absolute reasons, but compelling reasons that help people kind of look at their situation and say, you know what, this might be the better choice for us. So again, diminished ovarian reserve, or maybe excessive ovarian reserve, or high risk of multiples, tubal issues that can't be addressed surgically, or are limiting our opportunities for eggs and sperm to meet, lower sperm numbers, or lower access to sperm, and then again, the genetic testing for those single gene defects, or testing chromosomes in the embryo to look for a correct number. So let me look at these questions and see how we can answer those. So what are the chances of having a successful IVF treatment with other conditions like PCOS or overweight women? So it's a good question. So with PCOS, like I said, that's kind of that category where you have tons of eggs and your ovaries it's like throwing gasoline on a fire. It's just we put in a little bit of those injectable medicines, and man, those ovaries really light up. And that's exciting for me to see in an IVF cycle, because I know that those are good eggs that we're going to be able to use and expose to sperm and have a good chance of finding one that's going to work. It's kind of a dangerous and apprehension-provoking thing that we see when we're only trying to get 1 or 2 or 3 eggs at a time, because it's hard to tell that ovary to quiet down once it decides to light up. So with IVF, the chance of women that have PCOS becoming successful in a pregnancy with IVF is quite high because we usually do have a lot of eggs. We are able to have a lot of different egg and sperm combinations. So generally, women with PCOS are actually in a good prognostic group when it comes to thinking about IVF. And again, from a cost effectiveness standpoint, while IVF generally costs more than an insemination cycle, you could go through a lot of IUIs and not get pregnant, or you might be able to go through one IVF cycle and have enough embryos to build your family over time. And that can be a good thing. So how many eggs do you try to freeze or fertilize per cycle? That's very much kind of dependent on the situation. I would say most couples decide to expose all of the eggs that we obtain with sperm. And the numbers of eggs we get depends on your age and your ovarian reserve. You know, the fewest eggs I've ever gotten is 1, and the most eggs I've gotten is probably somewhere in the 50 to 60 range, and that's a lot of eggs. Now, if we're in a position where we have too many eggs, right, then too many eggs for that particular couple, then we have the opportunity to freeze some of those eggs, right? We don't need to put them all with sperm. We don't need you to end up with 30 embryos you're not going to use, but we do have an opportunity to freeze those eggs, choose some number of eggs that we're going to expose to sperm, hopefully get the embryos that we need out of that set. And if we need to reach for those frozen eggs again later, we can, and then you don't have to go through all the stimulation part again because we already have the eggs ready. We don't have to worry about all that. So that is an approach that we talk about because some couples, rightfully so, don't feel comfortable with having an excessive number of embryos or might feel kind of squeamish about going through IVF for a lot of other reasons and have an opportunity to, possibly build a family of the size that they're hoping for without having excessive higher number of be in a situation that they don't want to be in. So let's see. Somebody had asked specifically about a genetic syndrome and whether or not it would be wise to do IVF. That is something that we do have patients come to see us with. It really depends on what genetic syndrome it is and what are the adverse effects of that syndrome and whether or not that's something that you would want to screen for in your offspring. So some people might have something where the child would inherit something that is devastating and leads to early death. And I think everybody can agree that we don't want that situation to happen, and a lot of people would feel compelled to move forward with IVF. And tell you another example, some people might find out that they have one of the BRCA genes that makes them more susceptible to breast cancer, right? And they have made it to adulthood and they have survived their breast cancer, but they feel like they really do not want to pass along that gene that's going to make their son or daughter have issues with breast cancer in the future. And so they will choose to do IVF to say, you know what, I'm willing to transfer these embryos, but I really want to know up front if this embryo is going to have this genetic problem, or is there a way that we can choose to build our family and not pass along this, cancer susceptibility gene. And that is a situation where some people will do IVF. Certainly, we'd encourage you to talk with a genetic counselor about your condition because there are some genetic diseases that have a very well-defined mutation where we can check for that in an embryo. There are some other genetic diseases that might have multiple components and it may be more difficult or not possible to be able to screen those embryos. So it's very much on a case-by-case basis. So what is the maximum age when it's safe to do IVF? That's a good question. It depends on who you ask. So as far as, thinking about safety, right, we want to make sure that everybody goes through IVF, who goes through IVF is doing so in a safe manner. With IVF, we want to make sure that we can easily access the ovaries and that we're not putting them at undue risk from an anesthesia standpoint, making sure that they are that they have a generally lower than we want to make sure that their BMI is not excessive, that it's going to risk airway issues during the procedure. As far as age, that's a conversation to have with your physician. There are some places which will put an age cutoff as far as when you can safely do an IVF cycle and have a reasonable chance of a pregnancy using your own eggs. If there is an age cutoff at most clinics, it's somewhere in the mid 40s, around 43, 44, 45, depending on who you ask. And that's because the chance of pregnancy using your own eggs is usually approaching or lower than 5% at that point. And that's why those clinics put those criteria out there. Not all clinics have those criteria. Some have more strict criteria, some have more lax criteria, but you'll have to check with your clinic to see if there's a maximum age that you can do IVF. Let's see. Is there a higher success rate with a fresh transfer of a recently fertilized egg versus a frozen embryo? Also a good question. So nowadays, it's more common for people to do frozen embryo transfers. Really, the chances of pregnancy should be the same, possibly slightly favoring the frozen embryo transfer. The reason why is that when we stimulate the ovary to make multiple eggs at once, we are overstimulating the uterine lining sometimes, and then that means that the eggs and the uterus are no longer synced up. And if that happens, then we can take the prettiest embryo, but if we put it in at the wrong time in the uterus, then it's not going to be able to implant. So oftentimes we will freeze the embryos when they make it to that ball stage, what we call blastocyst stage, and we'll allow that person to have a period and put the embryo back in a much more natural cycle when their hormone levels are at a normal level and not a crazy high level that comes with IVF, and it improves the chances of implantation, decreases the risk that that baby's going to have placenta issues or low birth weight or preterm deliveries and things, and potentially may make it a much easier pregnancy for the woman that's going through. So what else? What is the maximum age or deciding factor of when a woman can no longer use her frozen eggs? So our professional society, which is ASRM, puts out guidelines for how we take care of patients, and pretty much all good clinics are going to be following ASRM guidelines when it comes to thinking about things like age cutoffs and whatnot. So currently the recommendation is for women that are seeking pregnancy that we should be able to get you pregnant before age 55, right? Because we want you to have enough time to see that pregnancy through delivery and adulthood. So we generally will have patients, if they're using their own eggs, donor eggs, whoever it is, we want to make sure you're pregnant before 55. That doesn't mean you have to use your own eggs, right? In fact, most people at age 55 are not successful using their own eggs, or have already gone through menopause. So they're using donor eggs or donated embryos. But age 55 is generally the cutoff for when you can transfer frozen embryos, whether or not they came from your eggs or a donor. As far as other medical conditions that might be advantageous to do IVF versus not, somebody had asked about Hashimoto's thyroiditis. So that's a thyroid disorder that can cause sometimes overabundant thyroid hormone. Sometimes it can cause issues with deficient thyroid hormone production. We want to make sure your thyroid is in a good range and a safe range for you to be able to handle a minor surgical procedure like IVF. But generally, it's not a contraindication. I see that and I say, that's great. We take care of patients that have Hashimoto's quite commonly, and it would not prevent you from being able to go through IVF. And as far as whether or not you asked about irregular periods and if there's a possibility to use your own eggs, absolutely. I find that that's actually a common misconception that I have among couples. Sometimes they say, you know what, I was told I have PCOS and I have irregular cycles and I need IVF, or, I don't know when my cycles are happening and I need IVF. And IVF is a great tool, but it's not the only tool. Remember, tubes are blocked. That's a good tool. Sperm numbers are absent. That's a good reason. But just because you have irregular cycles or you have PCOS, right, that's an egg access issue. And there are other ways to fix that. IVF might be a good tool, but it's certainly not the only tool. What causes IVF not to work? That's a good question too. So thinking about, people go through IVF and they say, well, what, if you're ensuring that all of these things are happening, why does sometimes IVF not work? And that's a great question. And I wish that I could tell all of my patients, 100% of the time that IVF is going to work and they're going to have a baby to go home with. What IVF does is it optimizes everything we know how to do from a reproductive science standpoint. But in and of itself, IVF does not correct genetic problems with eggs, in the sense that we cannot make the embryo have the right number of chromosomes, right? We can't make the sperm fertilize the egg, even if we're putting the sperm at the doorstep, which is called ICSI, when we put the sperm right next to the egg or inside the egg. We can lead the horse to water, but we got to have the horse drink, right? And in an IVF cycle, we are maximizing the numbers of eggs we can get, and we are optimizing those very best quality sperm to be the ones that find the eggs, and we can provide a beautiful environment for those embryos to grow and divide. And if they're a little bit sluggish in development, we'll wait for them and we'll get them to that stage where we can cryopreserve them. And IVF a lot of times will give us a window into what's been happening kind of this whole time with a couple's struggle for getting pregnant. We'll be able to see and be able to say, you know what, it looks like these embryos are not progressing beyond this certain stage. So, but in and of itself, IVF is a tool, but it's a tool that has its limitations like everything else. So sometimes in an IVF cycle, very uncommonly, but sometimes we do find an issue that we're not able to overcome through the technologies that we have with IVF. And that can sometimes be a reason that IVF doesn't work. Or if somebody has really low ovarian reserve, we don't get more than 1 or 2 or 3 eggs, even with the most aggressive stimulation. And we know that not every egg's going to fertilize or continue to grow and divide. And sometimes, you know, couples may end up in a position where they don't have a suitable embryo to transfer. So those are some reasons why IVF may not work in all situations, but it is by far and away the most aggressive tool we have. And again, it can be the only option for some people, but for most people, it is one of several options that can be employed. So it looks like we are just about out of time. So I am going to kind of bring this to a close. And if you have additional questions, I encourage you to continue to ask them and reach out so that our team can address those. And certainly you can go to the TFC website at txfertility.com and ask questions that way and get an answer back from one of our many helping hands. So anyway, do you need IVF? If you have a tube issue, if you have a sperm issue, there's some absolute reasons why you do need IVF. For most all situations, IVF is a great tool that we have, not the only tool we have, but a great tool we have to optimize the chances of finding that right egg and sperm sooner than later to help you build your family that you've been dreaming for. So like I said before, my name is Dr. Erika Munch. I'm in the San Antonio location here at Texas Fertility Center. I have 6 other colleagues that work with me, and if any of us would be happy to help you. I hope that we have found this information helpful for you guys this evening, and thank you so much for joining me. And with that, I will wish you a happy holiday and enjoy the rest of your evening.